hospital where they're really working on developing some new technologies, embracing new technologies that I thought I could bring to the area, and so here we are.
So you're a heart surgeon.
Heart surgeon, that's right.
That's a stressful gig. Do you ever wake up in the morning and you're not 100% and you go, but see, you have to go to work and it's not, I can do radio and I can just bomb and no one's going to die. Talk about a job with some stress. You can't drink, you can't have shaky hands, right? I mean, you have to get a proper amount of sleep.
Well, you know what they say about heart surgeries? It's not difficult to do heart surgery. It's difficult to be able to do it. Basically, it took a lot of years and a lot of training, a lot of education to get to the point. Once you're there, you could probably learn it. You pick it up in a couple of days. You're not allowed to.
No, but I see what you're saying. So once you learn it, it's like surfing big waves. You can't just paddle out. You'll get beat up. But if you train for 10 years, then you can take off on a double overhead wave.
If I went out on the big waves that you were on, I think I would struggle.
You get pounded into the ground and go, okay, I need to train more on little waves.
That's exactly right.
So once you're fully trained, then you wake up, it's just like going to work for anybody else.
That's exactly right.
You just train a lot harder and longer. So what are we going to talk about this morning? AFib?
AFib, that's right. So what's AFib?
Please.
So it's called atrial fibrillation. It's a irregular rhythm of the heart, and a lot of Americans struggle with it. Somewhere in the 3 to 5 million, and worldwide, it's actually becoming somewhat of an epidemic as well, and projected to increase in terms of the population as the population gets older. So AFib is a electrical disorganized rhythm, basically a series of short circuits in the heart.
Is it a murmur?
It's not a murmur. So a murmur usually is turbulent flow through a valve. And sometimes AFib can be caused or generated because of valvular problems. But a lot of times people have this arrhythmia just for no reason other than bad luck. And the problem with it is it causes often a racing heartbeat. So when people first start to notice it, they have these palpitations, or this feels like the heart's going to beat out of their chest, and their heart rate may be going anywhere from 120 to 180 beats per minute, with the normal rate being 60 to 100. They can get faint. They can feel like they're going to pass out, and they actually can pass out. And over time, that rhythm can start happening more and more frequently. And so it's a real lifestyle affector. It basically can make people afraid to go on trips. It can make people that are avid skiers, hikers, outdoor enthusiasts like yourself.
Right. Anything that gets your heart pumping, your adrenaline rush could be an issue.
Yeah. Now, so in this particular circumstance, though, it doesn't even have to be stimulated by an activity. You could just be sitting on an airplane and have it happen. And that can be something that's obviously very distressing to people. And you can even have that. One of the symptoms can be this impending feeling of doom, like something bad is going to happen, right? Quote, I'm going to die. I feel like I'm going to die.
Not a good feeling on an airplane.
Not a good feeling anywhere, really.
No.
Now, over time, if you have atrial fibrillation or AFib all the time, you may not have that sensation as much of the racing heartbeat. It's there. It's actually racing in the background, but that may wear off, and you may just feel tired, fatigued, because basically the upper chambers of the heart, which are fibrillating, which are fluttering instead of normally beating, contribute about 20% of your cardiac output. So you're losing about a fifth of your pump function when you're in AFib.
Uh-oh.
Right. So when we are able to fix it, if we can get you out of atrial fibrillation, and oftentimes people that have it go in and they get shocked in the emergency room, they get a cardioversion, they will feel immediately better.
That's the paddles?
That's the paddles.
Okay.
Exactly.
I've seen TV.
That's a first-line therapy for AFib if someone comes in and is unstable, or say it's their first time having it. That immediately usually initiates a trip to the doctor, and you get put on some medications. The problem with medicines for AFib is that they often cause as bad as symptoms as the actual process itself. The AFib, it may keep you from having these episodes of racing heartbeat, but when you get to that point where you've had it a long time and you're more fatigued, those medicines can also cause some of that fatigue. It can cause a clouding. Sometimes they can cause anything from gastrointestinal upset to just not really feeling 100%.
Coumadin?
Coumadin is the blood thinner that goes along with AFib. Basically, if you have atrial fibrillation and you have certain risk factors, you're at risk for stroke. So one of the number one causes of stroke, one of the primary causes of stroke in this country is atrial fibrillation. When blood flows through the heart, if it's not flowing very fast, it will stagnate. And it stagnates in a portion of the heart called the left atrial appendage. And if blood's not moving, it forms clots.
Uh-oh.
And then those clots can fire off to other parts of the body. And that's
why Coumadin comes in, because it keeps the blood clear. It's thinner.
It thins it out. It thins it out. And as anyone that knows that's been on Coumadin, while it can be somewhat life-saving to keep you from having a stroke, it can also have significant effects on your lifestyle in terms of if you're, like we said, an avid sportsman or a skier or a hiker, or if you just slip and fall and bump your head and you're on Coumadin, it can be a problem. You can certainly cause just as many problems as it can help. Now, with that said, patients that are older or have high blood pressure or other heart problems, if you're not on a blood thinner and you have atrial fibrillation, you have a pretty significant risk of stroke.
Okay, so best move is go see you, and then you'll decide whether you get an operation or Coumadin. Or both.
Well, I think there are definitely some steps along the way, and surgery is an option that a lot of people don't know about. There are also catheter ablations, which electrophysiologists, cardiologists can do as a minimally invasive small procedure through the groin. My procedure that I've been doing down south of here, and that we're bringing up to Napa Valley, is more of a hybrid approach, where we can do some surgery, we can do some catheter procedure, but like you're saying, the most important thing is everyone's an individual. The best approach for them really has to be tailored to their degree of atrial fibrillation. Have they been on medications before? Have they failed medications? How is it affecting their lifestyle?
So. Okay, this really interests me. You can do that groin shot, which is kind of like a angiogram. What do you call it? Is that what do you call it?
It's similar, very similar to angiogram.
Right? So, but you cruise up a big artery with a little tube. I'll put it in layman's terms.
Yeah, in this case, it's a vein. But
it's a vein, okay, but it's a big vein because you got to put some sort of scope through there so you can see, right?
Well, what they do is they put wires and catheters up through the groin, and they're looking at the body under fluoroscopy, so under X-ray. And under X-ray, the cardiologists are able to put catheters up to the heart, and then they have little ablation devices where they can burn lesions on the inside of the heart. And the reason we burn is because you're trying to create a scar tissue. Electrical activity in heart cannot cross scar tissue. So if you burn certain lines, and this is all based originally on a device called on a procedure called a maze procedure, which basically, if you form a maze, like literally like a maze where the electrical current can only go one direction through the heart, then it'll stop having the short circuits that cause all of this disorganized rhythm to form. So that when they stick a catheter up the heart, they burn lesions to primarily isolate the veins that come from the lung back to the heart, which is where 90% of atrial fibrillation originates.
Okay. I got half of that. I was trying. I was fully engaged, but I think I got it. It sounds dangerous. You're burning up inside the heart through a tube with a scope and an X-ray.
Right.
Why do you have to go to school so long?
Well, it's always a risk-benefit analysis on someone who wants to have a procedure versus just stay on medicines. And often when patients decide it's time for a procedure, it's because they've really been suffering with the disease and they don't want to live like that anymore.
So do you still crack the rib cage and open that up and get on in there?
So for my surgical portion, we don't have to, the old standard surgery was, break the breastbone down the middle, put people on pump, cut the heart, and sew it back together. We don't have to do that anymore. Now,
you don't?
Not anymore.
Oh, thank goodness we passed that. Okay, because that's just gnarly. And it can't be a good day at work when you got to rip somebody's middle wide open.
Well, I'll tell you, that's not, it's still not uncommon for other forms of heart surgery, bypasses and valve replacements. It's still kind of the way we have to do it. I'm reluctant to say crack your chest. That's a
but
term
that's
that
what you're
people
doing.
hear.
You're cracking it in the middle.
In a sense, we are precisely surgically sawing through the breastbone.
Well, okay, yeah, you're not just here. Somebody get a mallet and a chisel. We cracked it.
Exactly. But no. With this surgery now, it's all port access. So we put 5 millimeter to 1 centimeter holes on the side of the body while you're totally asleep under general anesthesia. The whole procedure takes a couple of hours.